and welcome to this special broadcast. Every life is invaluable, precious. When medical emergencies like a cardiac arrest happen, it is so important to be prepared. Now, you can actually really help someone in a medical emergency only when you're really clear about what has to be done in such a situation. Let's talk about the recent past alone. So many people passing in their prime due to a sudden cardiac arrest. There have been so many instances of such deaths making headlines as well. But the reasons behind these incidents and what we could do perhaps to intervene are still not clear. Now, worldwide, millions of people are dying of sudden cardiac arrest every single day. This is partly due to limited and sometimes ineffective CPR, that's bystander cardiopulmonary resuscitation. Many adults in cardiac arrest can actually be revived if bystanders provide immediate CPR in the correct manner. And raising public awareness and understanding of practical applications of CPR is an essential strategy for this to happen. It is perhaps even more important to learn CPR and learn about CPR if you have a loved one who actually has a history of cardiac disease, as research reports that the majority of such cardiac arrests actually occur at home. Save a Life is an initiative through which people are being educated and made aware of the early signs and symptoms of cardiac arrest so that patients can get to the hospital in time and also can be trained, people can be trained in giving CPR if the need arises. Well, today we have with us eminent cardiologists who can actually help you understand sudden cardiac death as well as the role of CPR to revive and save a life. We're very fortunate to have with us Dr. Arun Kochar, Senior Consultant Interventional Cardiology, Fortis Hospital, Mohali. Dr. Karandeep Singh Syal, Interventional Cardiologist, My Hospital, Super Speciality Care, joining us from Mohali today. We also have Dr. Rajiv Garg, Senior Consultant and Interventional Cardiologist, Aware Gleneagles Global Hospital, Hyderabad. Thank you all for being with us. If I can begin with you first, Dr. Kochar, obviously increasing incidences of cardiac emergencies in India. Is it specific to Indians, or are we just seeing these more because we're here and we're reading about them in the headlines? What is your impression of this as a practicing interventional cardiologist?
I think you are partially right that Indians are more prone for heart attacks and strokes. It has been seen that there is a genetical predisposition also. 30 to 40% of Indians have genetic variations which can cause heart attack and stroke. Apart from that, our lifestyle is such that heart attacks are happening more often in Indians. Junk food consumption, addiction to alcohol, drugs and smoking, corporate stress, and then living up to the competition, trying to do more, and obesity. These are prominent features that lead to more heart attacks in Indians. Post-COVID-19, there had been a spurt of heart attacks as well as other cardiovascular disorders, and it is kind of a post-COVID shock, aftershock, that is being experienced by all over the world and also in India.
Right.
Lastly, I'll just like to add that we try to ignore symptoms. We don't seek help when there are warning signs. Many celebrities who lost their life, they were having some symptoms, but they did not seek attention at the right time.
Mm-hmm. Right, that's a very important point that you're making, because I guess worryingly headlines have really been about so many people, celebrities even, who've had these sudden cardiac arrests while they're working out in the gym, while they're going about their ordinary lives. So, Dr. Syal, I'd like to ask you, what is it that can cause sudden cardiac death in young people or relatively younger people? And, is there any special care we can take to really prevent such incidences at all? Or, are they completely out of the blue and therefore unpredictable? Dr. Karandeep Singh Syal?
Nowadays, we have seen that more and more young people less than 30 years of age are coming up with a heart attacks or sudden cardiac arrest. And most important factor which we have observed is that the lifestyle we are living, we are more stressed. We are having lack of physical activity, and the addictions like smoking, having regular junk food, more saturated fat in diet, more of alcohol, and lack of physical activity. These are the things which can lead to heart attack in young population, and more and more people are indulging in these kind of activities or in these kind of fooding habits. More people are coming up with a heart attack less than 30 years of age. These are modifiable risk factors. There are some non-modifiable risk factors like genetic history. Genes are very important, especially in Southeast Asian countries. We are more prone to having heart attack in younger population rather than as compared to American population or Western world. So these are the modifiable and non-modifiable risk factors which can lead to heart attack or sudden cardiac death in young population. And most important factor coming up is lack of physical activity and more and more stress, which we are taking in routine or day-to-day activities, and trying to cope up with the speed of the life, what others are achieving and we are not achieving, and we are trying to run after these things, and we are creating more and more stress in our mind, and these are the factors which are leading to heart attack or sudden cardiac arrest in young population.
Right. Let me bring in Dr. Garg at this point. Dr. Garg, obviously sometimes regular checkups can detect the problem early and prevent emergency situations. But, in your opinion, who should be screened for these risk factors that could actually lead to sudden cardiac death? Are there sort of specific people who should be extra careful? Dr. Garg, you may have to unmute yourself.
Hello?
Yes, we can hear you. Go ahead.
Hello?
Yes, we can hear you, Dr. Garg. Please go ahead.
Yeah. So the question asked was, who should be screened for sudden cardiac death risk factors?
Yes.
The most important is patients with family history of coronary artery disease or heart attack should be screened for it. By meaning of family history, I mean if a male member in the family has an event in form of heart attack, undergone a PTCA or a bypass before the age of 45, or a female who has undergone the same procedures before the age of 55 should be screened. Second group of patients are those who are smokers, because smoking is a very important risk factor for having a heart attack. It knocks off 11 minutes of life in each cigarette. Then third group of patients are patients with high blood pressure. That is, definition of a high blood pressure according to the international guidelines is any blood pressure above 140/90 if you are a normal individual, and if you are having target organ damage in form of nephropathy or retinopathy or LVH, the level should be lowered to 130/85. Then patients with high cholesterol, that is, if the total cholesterol is more than 200 milligram per deciliter, or LDL more than 190 without risk factor and 100 milligrams with risk factors of hypertension, diabetes, or an event if like MI, PTCA or a CABG at level should be lowered to 70. Then patients with obesity. Obesity is a measure of body mass index, which is weight by height in meter square. Any figure more than 28 is called as obesity. Between 23 to 28 is high weight, that is overweight, and these are the patients who should be screened for sudden cardiac death. Then patients with arrhythmias like atrial fibrillation, patients, athletes who are having athlete heart, they are at a risk of sudden cardiac death during the course of aggressive sports. Then patients with long QT syndrome, then patients with devices, especially ICDs, pacemakers, and CRTDs should be screened for sudden cardiac death.
All right, that's a lot of categories, and I hope our viewers have been paying close attention to that. But Dr. Kochar, on a related issue, a lot of lay people will not know the difference between a heart attack and a sudden cardiac arrest. Can the symptoms be mistaken? What are the differences exactly? I mean, how is one to know whether it's a primary cardiac arrest or not?
See, the differentiation is very important, primarily because the treatment is also very different. So a heart attack happens when the blood vessel of the heart is blocked, primarily due to a clot. Such patients are conscious, usually, and they might complain of pain, burning sensation, lightheadedness, sweating, feeling uncomfortable. So that means the patient has got a heart attack. The other category which you told is cardiac arrest. These patients, they have an electrical problem. Remember, in heart attack, we had a plumbing problem where the vessel had a clot and the vessel got blocked. Here the electrical supply gets haywire, and because of that, the heart stops functioning. There is no heart function. These people do not have pulse, and they are usually unconscious. Not usually, they are always unconscious.
Right.
So these patients need CPR. Whenever you get a cardiac arrest patient, that means CPR is to be done immediately, and these patients need to get the first aid as soon as possible so that a life can be restored.
Right. Dr. Kochar, what a wonderful analogy there between plumbing and electricity, and thank you for sort of putting it out for us in such clear terms that anyone can understand. But Dr. Syal, does CPR also apply in both conditions? I mean, would you give it for someone having a cardiac arrest and a heart attack?
As Dr. Kochar has explained, both are different things. Cardiac arrest can be after heart attack, patient can have cardiac arrest. There are so many other reasons in which patient can have cardiac arrest. Heart attack is one of them. As Dr. Kochar has explained, heart attack there is problem in the blood supply, and in cardiac arrest it is an electrical problem. When the heart doesn't get proper electricity or proper signals to pump, then there is a cardiac arrest. Cardiac arrest. Heart attack can be one of the cause of cardiac arrest, and there are so many other reasons which can lead to cardiac arrest, and heart attack is one of them. And if we see a patient with a cardiac arrest, we need to immediately see his pulse, carotid pulse. If the patient is unresponsive, and see his carotid pulse, and if it is not palpable, then we need to immediately start CPR, that is cardiopulmonary resuscitation. And it can be done by any layman if he or she is trained, or he or she is informed that how to perform a proper cardiopulmonary resuscitation.
Right.
It can be done in a mall, it can be done roadside, it can be done anywhere, it can be done at home by the attendants of the patient. If they know, if they have followed the training, or it takes around 30 minutes of training, and anybody can perform it anywhere.
Right. Dr. Garg, let me bring you in as well. Are there any instances when CPR should not be performed that we need to keep in mind?
Yeah, it's a very important question, and people should remember that. You can classify this into three areas: patients of ICU where we should not do CPR, patient being taken care at home, that is home rehabilitation and chronic illnesses, and road accident areas. So first let us begin with ICU. Patients with pre-existing disease which will prevent a meaningful recovery, I think they should not be performed CPR. Then patients with acute illness where the recovery is prevented, there you should not do CPR. Then patients who do not respond to acute CPR following the ACLS protocol for 20 minutes, and the patients after 20 minutes we should give up CPR. So this is in ICU setting. Then patients who are chronically ill at home should be left alone because probably they have been debilitated for a long time with the illness, and prolonged CPR should not be done. And on roadside, we should be very careful. Patients having breathing should be and pulse should be not attempted as CPR. There is a condition called as acronym ROSC, that is return of spontaneous circulation. Once the patient has, then we should stop CPR, but it should not be done in patients who are not going to have meaningful recovery from the illness, is the most important bottom line, either in ICU or at home.
Right. Dr. Kar, thanks for that very clear explanation. We will take a quick break at this point, but coming up next, lots more to talk about. What are the current guidelines for CPR in India and much more besides. We'll be back in just a moment. You're watching Health and Wellness Save a Life, an initiative through which people are being made aware of the early signs and symptoms of cardiac arrest so that they can get patients to hospital and even give them CPR if the need arises. And we've been in conversation with eminent cardiologists. Let me go right across to Dr. Kochar now. Dr. Kochar, can you tell us a little more about what the current guidelines for cardiopulmonary resuscitation are in India, who can perform them, when they need to be done, and anything else you'd like to share with us?
Well, Indian guidelines are a little different from the American guidelines, and Indian guidelines have come recently. Indian Society of Anesthesiologists, they have formed a council, Indian Resuscitation Council, which have formulated these guidelines, and they are slightly different from the Western guidelines. Number one, they have included regional language and Hindi in the algorithm so that a common person can understand how to perform CPR. Secondly, they have emphasized that a mobile phone can be used particularly on the speaker mode so that help can be gained in case a single rescuer is there. Apart from that, there are certain differences. Some drugs such as opioid antagonists, which are opioid antagonists are not included in Indian guidelines, which are quite common in US. So there are certain differences, but Indian guidelines emphasize the fact that layperson, a common man who witnessed a cardiac arrest, can initiate the CPR. Right. And that is compression only CPR, no mouth-to-mouth breathing ventilation required. That helps common people to initiate this noble cause. Right. Because if the heart is not working, the hands of the rescuer become the heart for the victim. Right.
But Dr. Syal, just to take this further from here, how does a layperson know if he or she is, performing CPR with the right technique? I mean, for instance, if I were to do it, how would I really know that I'm doing it the right way? What are the results I can expect to see? How would I know it's being carried out right if I've never done it before, even if I've learned the technique?
Okay. If you found some patient or a person lying roadside or in a mall or in a house or in a home unresponsive, we check the pulse of the patient. That is mostly carotid pulse. If it is not palpable, then we start the CPR. We call for the help. We call another person, and that is very important. Call another person as early as possible, and we should start the CPR. There is a ratio of 30:2. 30 chest compressions. It should be around 2-inch chest compression should be given in the lower 1/3 of the sternum, and 2 mouth-to-mouth ventilation. And after each cycle, we check the pulse of the patient. That is mostly carotid pulse, not the peripheral pulse, central pulse. And if the pulse is there, then we shift the patient to the nearest hospital and call the ambulance and nearest hospital for the further management and going into the root cause of the cardiac arrest and treat that. In most of the cases, it is heart attack, and we need to shift the patient to the cath lab and treat accordingly.
Right.
We need to open the blocked artery in that case and give the patient immediate relief if the pulse is arrived.
Yeah, go ahead, Dr. Sial, you were saying.
Yeah, if the pulse is arrived. There is an advanced form of CPR, that is ACLS, Advanced Cardiac Life Support, in which we use defibrillator, and that is performed by the trained personnel, like ICU staff and the doctors inside the hospital, and in which we use defibrillator. In most of the cases, there is ventricular fibrillation or pulseless ventricular tachycardia, in which we use defibrillator to correct the rhythm of the patient if patient is pulseless, and there is advancement to that is advanced life support. Advanced life support, if we add PCI or PTCA, that is stenting, and ECMO along with the ACLS. If we add these things, then it is advanced life support.
Okay.
And that is available in the tertiary care centers mostly. So CPR is a basic thing, and advanced life support we can provide. We shift the patient, we give the bridge to the patient with the CPR, and shift the patient to the advanced care with the help of ambulance, and do the.
So the CPR obviously is the immediate intervention that's needed in order to be able to sort of facilitate the sort of specialized care later on. But Dr. Garg, what precautions should existing heart patients take when they're traveling somewhere? Is there anything that they can do in terms of sort of really gaming for situations like this, if I can call it that?
No, you mean the precautions patient should take when flying?
Yes.
Okay, yeah. So most important is the duration of flight, if it is more than 8 hours and less than 8 hours. But all the patients with cardiac condition, most important is you should take your history and medication along with you in the flight. Second, stay hydrated during the flight. Third, prefer an aisle seat because it will enable you to walk in the corridor every half an hour so that you prevent the blood clotting in the legs and risk of DVT and pulmonary embolism is prevented. Then most important is get an ECG, TMT, echo before boarding a flight if you have a major event in the past. Then get necessary vaccination for COVID-19, hepatitis and influenza. Then most important is you can board a flight as early as 48 hours after stenting if you did not have a cardiac event in form of heart attack, that is MI. But if you have undergone a cardiac surgery, preferable not to travel by air for 12 weeks. Then if you had a stroke in form of paralysis, please do not travel for at least 3 to 6 months. Then if you are having uncontrolled hypertension or low blood pressure, or you are having an irregularity in rhythm in form of atrial fibrillation, kindly take precautions and do not travel unless it is corrected or guided by the cardiologist.
All right, that's very useful information to have.
Most important, I want to give you the incidence of heart attacks documented on a flight between 2015 to 21 are about 143 events, and most of them were when the flight was taking off. The most important thing we should remember for a cardiac patient is in the aircraft, because of high pressure chamber, we get dehydrated fast. So most important is remain hydrated. That's most important.
Right. All right. Thank you very much indeed, Dr. Kochhar, Dr. Garg and Dr. Sial for being with us on the show and answering a range of questions. We hope it's been useful for all of you, our viewers. Thanks for watching.